Honorable guests, ladies and gentlemen, good afternoon. Thank you for joining us for today's roundtable on health financing in the 21st century, the public and private lever in strategic purchasing. My name is Myra, and I'm from the Public Policy Institute of our Hong Kong Foundation and your MC for this event. We are all in for a treat today as we are honored to have amongst us some of the most top thought leaders of the field that will be sharing with us the latest discourse and trends that shape health financing. To kickstart this roundtable, may I invite Executive Director of our Hong Kong Foundation, Mrs. Eva Chang, to give her welcoming remarks. Eva, please.
Hi. Good afternoon, everyone. Professor Eng-kiong, Professor Sun Kwan, Professor Eng-kiong, Mr. Henry Fan, Dr. Donald Lee, all the online participants from our medical and healthcare sectors, ladies and gentlemen. On behalf of the Our Hong Kong Foundation, I would like to extend a very warm welcome to all of you to our exclusive virtual roundtable today. Well, with such a very distinguished audience on the line and in the room, it's hard for me to hold back and not do just a little bit of publicity. So please allow me to tell you that our Hong Kong Foundation has earned acclaim in the Think Tanks Worldwide Index published earlier this year by the reputed Think Tanks and Civil Societies Program of the University of Pennsylvania. More than 8,200 think tanks from 190 countries are assessed and evaluated. We are very happy to see that our Hong Kong Foundation was ranked among the top 60 domestic health affairs think tanks in the world. We are also very thrilled to see that our research report entitled Fit for Purpose, a health system for the 21st century, launched in late 2018, and of course, led by Professor Eng-kiong, was commended Best Policy Study Report produced by a think tank, along with another 160 reports so recognized globally. So thank you, Professor Yo. It gives us great pride and pleasure to work under your guidance, and we certainly look forward to your continued support. With reference to today's topic, and on a more sober note, I must say that health services around the world nowadays are hard-pressed to keep up with 21st century challenges. Like many places in the world, population aging and the growing burden of chronic diseases in Hong Kong are expected to put very heavy pressure on healthcare systems, financial capital, and has raised alarm bells in many areas of sustainability concerns. Well, in today's roundtable, our panel of local and international experts will shed light on the challenges and also the opportunities unique to financing healthcare in the 21st century. They will also discuss the financing levers that will address Hong Kong's healthcare needs as we all move relentlessly towards a primary care-led health system. So in a moment, ladies and gentlemen, you will be hearing from our panel of renowned experts engaging each other on this hot topic in a lively discussion. Well, let me also express my heartfelt thanks to Professor Sophia Chan, Secretary for Food and Health of the Hong Kong government, who is unable to join us. She had planned on coming, but she is not able to for very understandable reasons in view of the current pandemic situation. But we are very grateful that Professor Chen has kindly recorded an introductory remark dedicated to this roundtable today. So without further ado, let's see what Professor Chen has in store for us. Thank you so much.
Professor Eng-kiong, Professor Kwan, Professor Ng, Henry, Donald, distinguished guests, ladies and gentlemen. Good afternoon. It is indeed my great honor and pleasure to deliver this address at the Roundtable event organized by our Hong Kong Foundation. The Roundtable will discuss how to better balance the public-private lever in the delivery of healthcare services against the background of an aging population, high incidence of chronic diseases, and of course, most recently, the prevention and control of infectious diseases such as COVID-19 and the increasing demand and cost of healthcare. It provides a valuable opportunity for the distinguished speakers to share their insights and also expertise in the sustainability of the healthcare system, healthcare financing, and also public-private partnership. In Hong Kong, healthcare is provided by both the public and also private sectors. As a safety net, the public system ensures that no Hong Kong residents will be denied healthcare services due to the lack of means. To meet the need for increasing demand and also service enhancements, the government has substantially increased the public health expenditure over the years. Over the past 5 years, the recurrent health expenditure has risen from 56.5 billion in 2015 to 16 to 82.7 billion in the 2019-20, an increase of about 46%. The estimated recurrent budget in 2020 and 21 will be 87.1 billion, which accounts for about 18% of the total government recurrent expenditure. The public healthcare services in Hong Kong are heavily subsidized. The various outpatient and also inpatient services are more than 90% subsidized. On the other hand, about 60% of the Hong Kong healthcare professionals work in the public sector, but they serve 90% of the patients. In view of the public-private imbalance, the government has launched a number of initiatives over the years with a view to better utilizing resources in the private sector. I would like to mention, some of our work here. First is public-private partnership. The government has allocated 10 billion in the last term of government to develop PPP programs. Currently, the Hospital Authority operates 8 regular clinical PPP programs to provide additional choices for HA patients to use the services in the private sector, so as to alleviate the pressure on the public healthcare system. Services cover hemodialysis, radiological investigations, and also general outpatient services, etc. Generally, patients only have to pay the same fee as in HA, and HA will provide subsidies to the private service providers direct. There are also co-payment programs. Second, the district health centers. In a bid to shift the emphasis of the present healthcare system and people's mindset from treatment-oriented to prevention-focused, the government has embarked on setting up district health centers in all 18 districts to provide primary healthcare services through medical-social collaboration and also PPP. The first DHC in Kwai Ching District commenced operation in September 2019. We will continue to expand the DHC network to provide different levels of prevention services in health promotion, basic health assessment, consultation, and also chronic disease management. As a pledge, the government will establish the DHCs or DHC Express in all the 18 districts within this term of government. Third is the elderly healthcare voucher. Under the voucher scheme, each eligible Hong Kong elders aged 65 above is provided with a voucher amount to 2,000 Hong Kong dollars annually. The elders can use the voucher to pay for the private primary care services of 10 prescribed disciplines that best suit their health needs, including preventive, curative, and also rehabilitative services. The voucher provides an additional choice outside the public sector and also encourages elders to develop a close and also long-term relationship with their healthcare providers in the community. Finally, is the voluntary health insurance scheme. In addition, we fully implemented the voluntary health insurance scheme, or what we call the VHIS, in April 2019. The VHIS is a policy initiative introduced to regulate indemnity hospital insurance plans offered to individuals, with voluntary participation by insurance companies and also consumers. The government provides tax deduction to encourage the public to purchase certified plans so that they may choose to use private healthcare services when needed, thereby helping to alleviate the long-term pressure on our public healthcare system. Notwithstanding these initiatives, I know we need to reflect further on how to better address the public-private imbalance, sustainability of our healthcare system, and also the cost-effectiveness of our healthcare services. I look forward to the insights of the different experts from both Hong Kong and also overseas. At closing, may I wish the roundtable a great success. Thank you.
Thank you, Eva and Professor Chan, for your remarks. Now, let's proceed to the next session of today's event, which includes a round of presentations starting with Professor E.K. Yeo, Professor of Public Health, Director of the Center for Health Systems and Policy Research at Jockey Club of School of Public Health and Primary Care at the Faculty of Medicine at the Chinese University of Hong Kong. Without further ado, may I invite Professor E.K. Yeo up onto the stage to share his insights on purchasing for universal health coverage. Professor Yeo, please.
All right. Ms. Chang, distinguished colleagues, ladies and gentlemen, it's a great pleasure to be here this afternoon to this seminar. Unfortunately, we can't all be in person, but we'll be able to communicate now with new technology. The PowerPoints, where are the PowerPoints? Are they on the screen here? All right. Never mind. The PowerPoints will be shown on the screen, is it? Where are they? I can't see the PowerPoints. Anyway, when they're doing this, you just go in. I'll be talking about universal coverage and strategic purchasing, then the context in terms of segmentation of Hong Kong's health system. So they'll put in context in terms of what we'll be discussing. Then I'll cover a bit about purchasing from the private sector in Hong Kong, some of the things that Professor Chen talked about, and then how we should be looking at strategic purchasing for chronic disease. Why do we want to talk about strategic purchasing? Because healthcare financing has three essential functions. Most people concentrate purely on raising funds. So we always say that there's insufficient funding for healthcare. The second is pooling, because you need to pool the risks. Because you have a lot of resources, if you can pool, it's like insurance where you spread risks. So in insurance, when you spread risk, the premiums are low, so the cost will be lower. So the third and very important function, which is very little discussed, is strategic purchasing. So strategic purchasing is something which is important for any health system to look at. And in particular, because in universal health coverage, how do I move things? Someone's moving the PowerPoints. Okay? Next one. Next. Universal health coverage is defined as ensuring that all people have access to needed promotive, preventive, curative, and rehabilitative health services of sufficient quality to be effective, while also ensuring that people do not suffer financial hardship when paying for these services. So this is important because the context is that, next slide. For universal health coverage, one needs to look at how we are able to purchase using our existing resources or new resources to expand access to service and interventions, improve quality, advancing equity, financial protection, optimize efficiency, and improving outcomes. So universal coverage provides a focus for governments to see how they should be purchasing to achieve these goals. So we really want to improve the quality of care. We want to make sure that people are protected against financial costs of ill health. We need to look at the overall efficiency of the system, not just of the private, but the totality of the health system, public and private, and improve health outcomes for the population. Next one. WHO makes a distinguish between passive and strategic purchasing. So passive purchase is what we usually are used to. You have a predetermined budget, or sometimes simply just paying bills when presented for services to be or have been provided. So it's like when government gives a budget to an organization to say that this is what we want to purchase, these are the resources that I'm going to provide. Whereas strategic purchasing looks at this continuous search for the best way to maximize health system performance. So here we talk about the whole health system, not just looking at specific areas or services, but how the whole health system can be performed better by deciding which interventions should be purchased. So you look in terms of what are the greatest needs, how, and from whom. Next one. So strategic purchasing decisions, there are three key decisions: to identify the interventions or service to be purchased based on population needs, health priorities, and cost effectiveness. To commission, which is either to make, which is like in the context in the public sector, or buy, choosing service providers based on the capacity, availability, quality, efficiency, and equity. And then the third key decision, determine how to purchase, using either demand or supply side instruments. So government can use the vouchers as a demand side, or you can contract on supply side. And then contractual arrangements and provider payment mechanisms. Next one. Following the decisions, then one needs to look at the specific key purchasing actions, assess the needs, preference, and values, fill service infrastructure gaps, importantly, inform the population of their entitlements and obligations, ensuring that they can have access to these entitlements, having effective mechanisms for feedback and complaints, publicly report use of resources, and ensure accountability of the purchases. Next one. You all need to select providers in terms of purchasing actions, considering the range and quality of services, establish service agreements and contracts, develop formulas and standard treatment guidelines, develop, implement, modify payment methods to encourage efficiency, establish provider payment mechanisms, secure information, monitor performance, audit providers, protect against fraud and corruption, establish and monitor user payments. So this would be applicable whether you use a demand or supply side instrument. And when you look at what government does in terms of the public-private programs, many of these are in place, but not all of them. Next one. The next one I'll cover is Hong Kong's segmentation of Hong Kong's health system. Next. We're all familiar in Hong Kong that we have two parallel tracks of public financing and public delivery, private financing and private delivery. So when you look at the funding sources, 49% is from taxation, 35% is out of pocket. So very, very substantial. And I think Professor Soon-Min Kwan and Professor Ng will be talking about that in their own experiences. And of course, that's not very desirable, because with out-of-pocket payments, there's a danger of causing catastrophic burden to families to have to pay out-of-pocket, and sometimes even push them into poverty. Employers, small 7%, and insurance only 7% of the total healthcare dollar, although many people have insurance, but the coverage is quite limited. And the public provision, as Professor Chen has said, is that predominantly inpatients is public, and in the outpatient is predominantly private. So we have a stream of publicly funded, predominantly hospital services, and another stream of predominantly funded and provided private outpatient services. So this segmentation, in fact, causes a lot of inefficiency and compromises on the quality of our services. So one needs to look at the system in totality, not just at one sector, and that's why government is doing these PPP programs. Next one. This is the data on aging. As with aging, you have increase in chronic diseases. This is based on the hospital authority data. So by the time you're about 45, about 35% of individuals will have one chronic disease. Not only is that a problem, in the darkest shades are people with 6 chronic diseases. So as you age, not only do you have one chronic disease, but you have multimorbidity and up to 6 chronic diseases. By the time you're about 80, about 5% of people have that. And the second graph in green is just the updated figures of the year 2014. And you see that the numbers are even, the proportion is even higher. Next one. And this is the data from the thematic household survey. When you look at the mix of public and private utilization, so the top blue, purple part, when people don't have any chronic disease, 24% use public systems, 56% use private. But when they started having one chronic disease, they migrate to the public sector. So 81% use public and 59% use private. And 44.7% use both. So you can imagine the duplication of care and the discontinuity of care for people with chronic disease. And because the provision in the public sector is inadequate and the cost of the private care is inadequate, people will subsidize the public care with private care, right? Next one. And this is data that we looked at from the Hospital Authority. 46% of all admissions to hospital are what we call due to ambulatory care sensitive conditions. Next one. And 20% of readmissions are, within 30 days, 20% of patients are readmitted. So that is, denotes that our ambulatory care is insufficient. So when you look at what are these ambulatory care and conditions, where good outpatient care can potentially prevent the need for hospitalization, timely and effective outpatient care can help reduce the risk of hospitalization by preventing the onset of illness or condition, and early intervention can prevent complications or more severe disease. Next one. So you can see that with our segmentation with chronic disease, you have a lot of inefficiencies where because of inadequate public provision of primary care and the difficulty in linking up private care, you have a lot of readmissions to hospitals from chronic disease. So when you look at go back to the one before, purchasing from the private sector, has this been updated? Okay, next one, purchasing from the private sector. So this is the, I'll cover the elderly health voucher. Because the changes in design of the voucher, as you know, we have Professor Chan talked about elderly health voucher. It was started in 2010, started at $250, and then became a recurrent program in 2018 with $2,000 per person. So this is, the entitlement originally from people aged over 70 and above, and now it's for anyone aged 65 and above. And we did a research on this and evaluation of this voucher program to see whether it was meeting its objectives. Next one. Next slide. The voucher is used as an electronic platform. So elderly only need to show their Hong Kong identity card for registration. So the doctors will then automatically enter the individuals. So it's quite a simple mechanism for the elderly, right? But not necessarily for the provider. Next one. And when you look at the expenditure of the voucher scheme, it started off the expenditure of $40 million in 2009, and by the 2018, it's already $2.8 billion. We haven't got the updated figures because they have not been published yet by the government. Next one. But when you look at the voucher increase, the orange bars are the vouchers used for mainly acute episodic conditions, right? And the pink bars are the utilization for chronic disease, and the orange bars are the amounts used for preventive disease. So although government wanted to encourage utilization of preventive, but very few people use it for preventive service. It's mainly for acute episodic conditions and very little for chronic disease, which is in fact where the greatest need is. Next one. And when you look at because the vouchers could be used by 10 different private healthcare professionals, optometrists, dentists, doctors, chiropractors, Chinese medicine practitioners, physiotherapists, radiographers, nurses, etc. But you can see the utilization is very variable. With optometrists, 67%. And of course, we know why that's the case, because the elderly people are permitted to have spectacles if they need glasses, they can use it to purchase spectacles as a prescription. And the story is that many of the more wealthy older people use that to buy their fashion frames. And one of the problems when you look at physiotherapists and occupational therapists and nurses, it's surprisingly very low numbers, right? Because these are primary care practitioners. And I'll discuss that later because we've done quite a research on that, the different studies that we did. It's related to understanding of their roles and then also the amount of the voucher. Next one. Importantly, we looked at the perceived choice between private and public doctors. So when you look at the blue bars, right? The blue bars are the people that use both public and private. You can see that after using vouchers, the percentage of people that use both public and private has increased, right? Up to 61%. So we are really encouraging doctor shopping. And when you look at the total number that go to the public system, so it's the blue bar and the red bar in totality, which means that the people that use the public doctors, you can see that it's not only has not decreased, it has increased. So it's gone up from 73% to 78%. It may not be so significant, but certainly there's no decrease. And when you look at the green bars, which are people that only use the private sector, it's gone down slightly from 22% to 19%. So what this shows is that what we have achieved by the voucher is we've encouraged dual utilization of both public and private without any reduction in the use of the public services. Next slide. So in another study, when we looked at the data from the Department of Health and the Hospital Authority, so this is linked data. And when we look at the linked data of vouchers users, the orange bars, the orange line, are people who don't use vouchers. So these are the average number of outpatient attendance per person for people who don't use the vouchers. The blue lines are the people who use the vouchers. You can see that they overlap. So that shows there's no significant difference in general outpatient attendance between voucher users and non-vouchers each of the years of the voucher. Next one. So these are the voucher claims that we talked about. So you see that it's gone increased to 2.8 billion. Next one. In another study of focus groups about health professionals, we were trying to understand the utilization and the perceptions of use by the professionals. Elderly were unaware of the service, especially for allied health and chiropractic. So they didn't know what the service was being provided. And also they didn't know what nurses provided in primary care. Right? So they mainly use vouchers for curative cases or one-off, and they give the elderly opportunity to close. Some providers said they could lead to moral hazard and encourage voucher abuse. They also reported implementation barriers. There were heavy administrative burden, inconvenience from the reimbursement arrangements, insufficient communications with the government, and low income generated from the voucher. Particularly for the physiotherapists and occupational therapists. For each session for rehabilitation, they charge probably about $800, $700, and for a course of treatment, the voucher doesn't cover it. So obviously people don't go to the GPs, although you can co-pay, right? And the other problem is that physiotherapists and occupational therapists in private practice need a referral from a doctor, right? So then it becomes quite difficult for them to provide primary care as primary care protectionists if you need a referral. Next one. So vouchers are something that we need to look at because the government is providing this money. Should we provide the service ourselves or buy? In fact, this was a question asked by the journal when we submitted it for publication. And this is Professor Suman Kwan is the editor of this journal. They asked us whether it's more cost-effective to make primary care in the public sector than to buy from a private sector. So it's either to supply or demand. The cost for government for providing primary care in Hong Kong is $3.1 billion in 2018. The total voucher claim for elderly was $2.8 billion. So in fact, the public investments in primary care has increased by 90% with the use of the voucher. Right? Okay, next one. And this is the government's purchasing for primary care. So when you look at the totality of government is using, both in terms of its providing, so I include that even within the Hospital Authority and DH as purchasing primary care, and it's quite substantial. So within the Hospital Authority, about $3 billion is for general outpatients, $395,000 for family medicine. The GOPC, general outpatient public-private partnerships, the contracting with private doctors, as you heard from Professor Chan, is 211 million. Department of Health for preventive care, curative care, rehabilitation, over 6 billion. For the elderly healthcare voucher, 2.9 billion. Vaccination reimbursement, 2.9. And then I think this is the old PowerPoint. You haven't changed it. There's one on the district health system. So the totality of the Persian primary care in Hong Kong is 11.1 billion. So anyway, we can update that. Next one. Next one. So strategic purchasing decisions, you determine first the intervention service based on population needs, priorities, and cost effectiveness. Then you decide to make or buy, who to buy, for whom to buy, what to buy, from whom to buy, how much and how to pay, and then how you monitor. Next one. So there are a series of decisions. I won't cover them. Next one, because of time. Then you have the next one. Yeah, I think this is the old PowerPoint. So in terms of, one needs to look at the government's role in health systems, market failures, market segmentation, so we'll update this one, it's missing from this one, the public sector capacity, and then private health sector assessment. Next one. Who to buy, obviously, it's not just the government. It could be the health boards or hospital authority boards. It could be purchasing agencies or in the private sector. Next one. Then one needs to look at for whom to buy, looking at the UAC. Next one. What to buy. And for purchase to be strategic in its services it buys, you need to look at what services should be delivered as a priority for integrated care, the information in terms of burden of disease, how cost-effective are interventions, the staff and facilities, and how the interventions are currently delivered, and then what are the projections of resources required. Next one. So I'll end here by talking about what we should be doing for chronic disease, what to buy. So the target, obviously, when you see the discussions that I've been taking you through, chronic disease prevention and management certainly is something that we need to purchase strategically, right? Whether it's your make or you buy, and to address the problem of segmentation of public and private sectors. Next one. This was the data that we developed in 2016 in our first foundation paper. When we look at the incidence of hypertension, diabetes, heart disease, stroke, and cancers, you can see that it decreases quite rapidly after the age of 45. Right? Next one. So how does a voucher work? It's a consumer-led demand-side financing tool, which is more effective, is targeted as a specific group for specific health services, which are well-defined, time-limited, in particular for those that are underutilized. Next one. So what and how to buy? Because the voucher is intended only is used not for complex diseases, not for undefined services. So if you want to use a voucher, it should be specific, targeted for a screening for chronic disease. And for chronic disease, in terms of chronic disease management, one should be contracting. Right? So because it's quite more complex to have a chronic disease management because you need protocols. You have a lot of variations because patients have different severity of illness. So it's not then suitable to use a voucher. Because vouchers, the experience with vouchers is effective only when it's used for very simple, well-defined types of interventions. Right? So in terms of how to buy, if government wishes to deal with chronic disease, the voucher would be useful for screening, and the contracting would be chronic disease management. Next one. So this is what we also looked at in 2016 in the foundation, when we then looked at if we had a voucher for low-income families and also chronic disease management, how much it would cost government. So you can see the gray bars are the cost of screening, and the orange part is the cost for chronic disease management. So this is quite limited. This is just based on certain assumptions, and it was targeted for people under the poverty line. So it just gives you, just demonstrates that the cost of this would be manageable. We are currently doing a feasibility study on a healthcare voucher for screening and management of cardiovascular risk factors associated with chronic disease in the general population, which is a mixed methods evaluation. The study is being funded by the Public Policy Research Funding Scheme, and the study is being done by by us in the Center for Health Systems and Policy Research in collaboration with the Hong Kong Foundation. The objectives is to evaluate the attitude, perception, barriers, and facilitators of the program, and to evaluate the comparative cost effectiveness of the program for triennial screening of diabetes, hypertension, and lipid disorder versus no screening among Hong Kong eligible Hong Kong residents. So this is, in fact, this study is just started, and we'll be presenting this towards the end of the year in the policy document on strategic purchasing. Thank you very much.
Thank you, Professor Yeo, for a most enlightening and informative presentation. To continue with this discussion, the next set of presentations will be delivered virtually. May I now first invite Professor Soon-man Kwon, Professor and former Dean of the School of Public Health at Seoul National University, and Adjunct Professor at the China Center for Health and Development at Peking University, who will be speaking to us about South Korea's experiences with strategic purchasing. Professor Kwon, please.
Thank you. Thanks a lot for inviting me to this very important and interesting meeting. So let me share the Korean experience of national health insurance and purchasing with you. Let me share the slides. So hope you can see this, correct? All right, so Professor Ye already gave you some overview about what is strategic purchasing. But let me show you that first, this is the Korean healthcare system and health financing is different from Hong Kong. So we have a so-called national health insurance. This is a public insurance, mandatory for everybody. So it has a universal coverage of population, but still out-of-pocket payments, we call it co-payment, at the point of service is relatively high, about 30 to 35% on average of all healthcare expenditure is paid from out-of-pocket, partly because national health insurance has a rather extensive benefit packages, but providers, they keep introducing new technology, new services, which are more expensive, and the health insurance sometimes do not cover those new technologies, sometimes do not have enough scientific evidence for cost effectiveness. So anyway, so these out-of-pocket payments consist of both the co-payment under NHI and also full payment for services that are not covered by national health insurance. Another very unique feature is that Korean healthcare system is predominantly private. 90% of the hospitals are private. However, there's a legal mandate. So there's no voluntary contracting between NHI and private hospitals. Rather, it's mandatory that all providers, both public and private, it's a mandate for them to join national health insurance system. So this is a rather very strong regulation and legal mandate. Another unique aspect is that which is different from Japan and Germany, for example, because as you know, Germany and Japan have a social health insurance style, but they have a multiple funds, multiple pools. Whereas in Korea, we have a single pool. There's one insurance agency. So that means we have a uniform contribution formula, uniform benefit packages, and uniform provider payment for all in Korea. And we have a single insurance agency called National Health Insurance Service. So we call it NHIS. So this is the basic feature of the Korean health insurance system. As EK already mentioned, that the importance of purchasing, so purchasing has a critical impact on the quality of care and financial sustainability. It should decide benefit packages, contracting with providers, quality level, payment level and method. And another very important element is how to make a decision. the decision-making process or policy-making process for the purchasing is another very important element. So first, what to purchase? This is so-called service coverage decisions. As you know, the benefit or service coverage determines the financial protection for the people, but at the same time, it also determines the financial sustainability of the healthcare system. In other words, if the benefit package is too generous, well, the financial protection will be good, but it may have a negative impact on the financial sustainability of the system. So these days, in the global community, we think that the key element is that the people should have a clear understanding of what they are entitled for, and also how much they should pay. So the clear understanding of the entitlement or service package is the key. And these days, many countries are facing a very rapid dissemination of technology and anti-cancer high-cost medicines. So more and more countries have this positive listing system such that they examine the economic benefits or effectiveness and cost of those technologies and make a benefit package decisions based on that economic calculus. But you know, this cost effectiveness is not all. We have taken into account other aspects like the burden of disease, financial burden on patient, budget impact, and clinical effectiveness. So it's like a multi-dimensional decision making, which services to cover by the purchase mechanism. So this is an example of the benefit package decisions of medicines in Korea. This is like a two-stage process. In the first stage, there is an economic evaluation mainly based on cost effectiveness. And so in other words, the manufacturers of medicines, they submit the data on cost effectiveness, and it is reviewed by technical agency called Health Insurance Review and Assessment, HIRA. So it reviews and makes a decision on the listing. And once it is listed, then at the next stage, there's a price negotiation between National Health Insurance Service and pharmaceutical manufacturers. So it's a price negotiation. I'm talking about the package decisions for originator medicines. For generic medicines, it's formula-based, but for the originator medicines, we have a two-stage decision process. And in the pricing decisions, there's a price volume considerations such that when you set or negotiate the price, you also take into account the volume, sales volume of these medicines. But as I mentioned earlier, it's very important the governance of this purchase mechanism and who and how to make the decision. At the minimum, we think that the decisions on the benefit package or service benefits coverage should be made in a fair and transparent way. So there's a so-called accountability for reasonableness, presented by a famous philosopher in health policy, Norman Daniels, who retired from Harvard. But he shows that there are several elements that we should take into account when we want to make a fair and transparent decision-making for the benefit packages, because this is a collective decision-making. It's not an individual decision-making. So as a society, or as a government, as a public sector, as a health, as a social insurance, which services to cover? This is very complicated decisions. And it's not just technical decisions, but it's a lot of value judgment. So again, Korea and many countries, we have this so-called technical committees consisting of experts. So these experts collect, verify, interpret evidences on cost and effectiveness of various services, various medicines. But based on that technical or scientific evidence, we should also take into account the values, because it's essentially priority setting. For example, suppose we have two different options. Option one, small amount of benefits to the large number of population. Option B, large amount of benefits for smaller number of populations. which suppose both are equally cost effective. Which one to choose is not a technical decision. It's more like a value judgment decision. We should take into account ethical concerns, for example. So this is very complicated, but there's increasing, global trend is that we are increasingly paying attention to what's the best way to take into account this value judgment of the general public in the decision making. And it's very important to take into account their preference, because they are the place they should pay the contribution, they should pay tax. Okay? So this value judgment is another very important element. That's the case in like a UK National Institute for Clinical Excellence, and also Korea is increasingly using this value judgment approach, like a citizens council approach to the service coverage. And also we have a tripartite committee style committee. So there's a major decisions on premium collection, premium levels, pricing, and benefit packages are made by this health insurance committee. But of course, this type of value judgment, there's a small committee, and this small committee provides their input to this health insurance policy committee. So there's tripartite, 8 from payers, 8 from providers, 8 from public interest. So payers are like those who pay contribution, and providers, healthcare providers, and these are representatives of their respective societies and associations. And these 8 from public interest, Ministry of Health and Welfare, Ministry of Finance, and 2 insurance agencies, National Health Insurance Service, Health Insurance Review and Assessment, and 4 independent experts like me. So I also serve this committee as a 4 expert. And also the Ministry of Health is quite strong. So basically, Ministry of Health and Welfare is a policy formulator, and insurance agency is more like a policy implementation agency. Provider payment, unfortunately, we mainly rely on fee-for-service. We have a DRG, but only for 6 disease categories. So it's a big threat to the financial sustainability of national health insurance. We have a regulated fee-for-service, but still there's a volume impact. Private providers tend to keep providing more and more and more services. We also have some pilot payment systems, of mixed payment system, mixture of fee-for-service, per diem, and DRG. So in a sense, the dominance of private providers coupled with the fee-for-service system resulted in demand inducement. So it's a negative impact on financial protection. And when government tries to reform the payment system, there's a huge opposition by private providers. And purchasing for quality of care is quite important, because we should guarantee the quality. This health insurance is a single payer, single pool, so it has a big purchasing power. So this HERA plays a very important role in the quality evaluation and improvement in quality through the review and assessment of medical claims. Basically, all healthcare providers, when after treatment, they submit the claim to this agency, and this agency review and assess, and this agency disclose the provider performance to the general public. So when you enter the website of HERA, you can easily find the performance measures of private providers. There are some small-scale pay-for-performance measures, and we also have a drug utilization review processes. So this is all very ICT, information and communication technology-based systems. And for example, this is like a website such that you can see, sorry, it's a Korean, but you can see the performance measures of each providers. Finally, this is a major challenge. I think Hong Kong is the same challenge. We have a very rapid aging of the population. So Korea, about 10 years ago, we introduced a separate additional public insurance for long-term care. So we call it long-term care insurance. But it's not for medical care. This is a long-term care. So it's mainly about elderly care, and which covers about so far around 8 or 9% of all the people. So although it's a separate insurance from separate from health insurance, but Health Insurance Agency, National Health Insurance Service also administers this long-term care insurance, but it's a separate funding. So same agency is responsible for two insurance schemes. One is the National Health Insurance, the other is long-term care insurance. But one of the big difference between health insurance and long-term care insurance is that there is a separate assessment procedure. So for long-term care insurance, an older person should apply. And then long-term care insurance assess their functional and cognitive disability and then make a decision. And anyone who pays contribution for NHI, they pay for long-term care insurance. So basically every citizen pays long-term care insurance contribution, although the benefit package is mainly targeting those over 65. Because for those over 65, it covers all types of long-term care. Whereas for those below, younger than 65, it only covers a age-related long-term care. So in terms of the number of people who currently use services under this long-term care insurance, about more than 90% are old people over 65, and less than 10% of the beneficiaries are from the younger generation. So in a sense, this is very clever because everybody should pay contribution, but the benefit package is more targeting for older people. So it's better for fiscal sustainability. But the major challenge is that it's like, again, purchasing, because this long-term care insurance, they purchase both institutional care and home-based, community-based care. And we hope that there's a more utilization of community-based care because it's cheaper than institutional care. But still, the coordination between institutional care and community-based care is very difficult. And also the coordination between health insurance and long-term care insurance is not easy. In theory, it's very clear because health insurance covers healthcare and long-term care insurance covers long-term care, elderly care. But there are some people, many older people need both. So some people, when they stay in geriatric hospital, sometimes we hope them to be discharged to long-term care facilities, but many of them still stay in geriatric hospital. They do not want to move to long-term care facility because they think that they feel safer when they stay in long-term care hospitals because there are nurses and doctors in the hospital, whereas when they move to long-term care facilities, there's no doctors. So the coordination between health insurance and long-term care insurance is not easy, even after 10 years ago, we already introduced long-term care insurance, but coordination between two different insurance schemes is still a challenge. This is annual rate of increase in healthcare expenditure, very rapid increase in health expenditure. The population aging, I think a similar case in Hong Kong. We are very much worried about the high, speedy aging process that Korea has been experienced. This is my paper on UHC. So this is my presentation over. Thank you.
Thank you, Professor Kwan, for your sharing and invaluable insight. May I now invite Professor Chiu Wan Ng, Professor of Public Health at the Department of Social and Preventive Medicine at the University of Malaya, who will be speaking to us about Malaysia's experiences in financing universal health coverage. Professor Ng, please.
Good afternoon, and thank you to the organizers for today's meeting for inviting me here today to share with you Malaysia's experience in a new national program to buy primary care services from the private sector to benefit the poorer households. Now, if I can just share the slides. Okay. But first, before anything, I'd like to give you a brief introduction to Malaysia and her healthcare system. Malaysia is an upper middle income country with a relatively young population of about 32 million people. It's been said that we have had universal health coverage for a very long time, since the 1980s. Malaysian citizens can access comprehensive healthcare services from primary care to tertiary care from an extensive network of public healthcare facilities. These services are funded mainly from general taxation, and we have been able to keep our user fees relatively low. Like Hong Kong, but unlike South Korea that you've heard just now from Sunman, Malaysia has a dual public and private healthcare delivery system. However, unlike Hong Kong, in Malaysia's case, the public sector is a dominant provider of both hospital-based, secondary and tertiary care, as well as primary care services delivered in the clinics. We have the federal agencies, the Ministries of Health, Higher Education, Local Government and Housing, and Ministry of Defense, which operates clinics and hospitals throughout the land, providing mainly Western care medicine. Traditional care, just like Hong Kong and South Korea, are available in Malaysia, but only in the private sector. We have noticed that there is an increasing trend in utilization of public outpatient services, from 49% of all outpatient visits in 2011 to about 64% in 2019, last year. However, the pattern of hospital admissions remain unchanged. About 75% of our hospital admissions are in the public sector. There has been a very gradual increase in health expenditures in Malaysia. In 1997, this totaled about 3% of GDP. It has increased to about 4.2% of GDP now in 2017. Half of these expenditures come from the public purse. And it is a feature in Malaysia that most public care are mainly financed through the public purse, general taxation, and private care mainly financed from private sources, mainly out-of-pocket payment. Just like Hong Kong and South Korea, out-of-pocket payment is a substantial component of total health expenditures in Malaysia, reaching to about 1/3 of the total expenditures. Our healthcare system has generally served us well. Okay, combined with the other benefits of economic development, it has led to improvement in health status, as seen in this slide. Most of our health indicators are now approaching those of range, can be seen in the level of urbanization. In 1980, only 1/3 of our population lived in towns and cities. Now, 3/4 of our population are urbanites. The slow changing structure of our society has led to a change in the pattern of disease burden, from communicable diseases to non-communicable diseases. Although communicable diseases like dengue and now COVID-19 are a public health concern, are still a public health concern, but we have noticed increasing burden of non-communicable diseases like diabetes and hypertension. Successive national household health surveys have documented the increase in the burden of NCDs, especially in burdens of diabetes and hypertension. But what is more alarming to us, if you look in this slide, is that more than half of the people with these conditions were not aware that they had diabetes or hypertension, and therefore had never received appropriate medical treatment for their condition. In addition, there appears to be an income gradient in NCDs. Adults from poorer households are more likely to have diabetes, hypertension, as shown in this slide, and they are more likely to be unaware that they had these conditions. These findings seem to lead to a conclusion that there appears to be a gap in our delivery of primary healthcare services in Malaysia. Malaysia has a very long established system, public system, to deliver primary care. However, our strengths are in services for maternal and child health services, as well as services targeted at prevention and control of communicable diseases. And this is being tested right now in our efforts to control the spread of COVID-19. NCDs are a latecomer to the scene, and the way we tackle it is through opportunistic health screening services, meaning we only test people who walk into our clinics for other conditions. We don't go out into the community to actively search and for people to be tested. And this is perhaps one of the weaknesses of our system. Diabetes and hypertension are not the only NCDs of public health concern. The other is cancer. Malaysia has about 120 incident cases of cancers every year. Despite having said that we have universal health coverage, a very recent study showed that about 45% of cancer patients suffer catastrophic payment in the first year of treatment. But on further analysis of this study, we found that cancer patients who go to our Ministry of Health hospitals suffer financial difficulties, not actually in payment for the cancer care itself, but payment for other associated costs, such as transportation. In view of all these health needs, the government of Malaysia, in its 2019 budget speech, announced the establishment of PERCA B40. PERCA B40 is a national program targeted at health screening of individuals aged 50 and above, coming from the poorest 40% of households. And in 2019 budget speech, 100 million ringgit Malaysia has been set aside for this program. The program was officially launched last year in April. The beneficiaries are recipients of what we call the government's Household Living Aid Program. Household Living Aid Program is a program aimed at providing financial assistance to households earning less than approximately $1,000 a month. And the main health benefit of this program is in health screening. Although the other benefits are financial assistance for people to purchase medical equipment like hearing aids and wheelchairs, and financial incentive for people to complete cancer care, and also financial assistance for transportation costs to hospitals for cancer care. These maps show you a distribution of our clinics in Malaysia. The red refers to public clinics. The blue refers to the private clinics. Most of our clinics in Malaysia are in the private sector. And the private sector clinics are mostly located in the more populous west coast of Peninsular Malaysia. The government has entered into a contract with private clinics as well as private labs. Private doctors do a complete history taking. They do a physical examination and take blood specimens, which are then sent to private labs for testing. To date, The program is only about a year old, and although we have not reached our initial target of testing and screening 800,000 people by now, we have screened only about 350,000 by June of this year. The government has released information to say that about 40% of those screened have found to have one or more NCDs. To date, about 1/3 of our private clinics have volunteered to join the program. I'd like to conclude by this slide, just to say that Malaysia's tax finance primary care system has had actually a very good track record. However, we need to make changes in the way we deliver and finance care to meet the new health challenges. In particular, I need to say that we need to explore to figure out a bigger role for our private sector to complement our public sector in delivering care to promote and maintain universal health coverage. And in this context, although the jury is still out, this PERCA B40 program, to me, is a start in the right direction. And with that, thank you.
Thank you, Professor Ng, for the thought-provoking presentation. And now, a kind reminder to submit questions either in English or Chinese for our Q&A session after the panel discussion. And now, may I first invite Professor Yeo to the stage for our panel discussion. This will be moderated by Mr. Stephen Wong, Deputy Executive Director and Head of Public Policy Institute of our Hong Kong Foundation. Virtually, may I invite Professor Kwon and Professor Ng to remain with us. Joining this strong lineup, I also take pleasure in inviting Mr. Henry Fan, Chairman of this hospital authority, and Mr. Donald Lee, President of the World Organization of Family Doctors, to join us. Now, Stephen, I hand the time over to you.
Thank you, Myra. It's been great to get all the insightful observations from all our respected professors. And now, maybe I would ask Mr. Henry Fan, as Chairman of the Hong Kong Hospital Authority, to really share his view with us from his perspective of HA with respect to strategic purchasing as well as public-private partnership. Henry? I think your voice is, can you unmute? The sound is still not there yet. I'm sorry. Maybe I will invite Mr. Donald first, if that's possible, as we fix the technical issue. Donald is the president of the World Organization of Family Doctors. And Donald, Dr. Lee, do you have, can you share with us from your perspective as family doctors, how the strategic purchasing or vouchers would help with the development of primary care in Hong Kong?
Certainly, and thank you for inviting me, and thank you for the opportunity to make some comments, some general comments, and then something about our Hong Kong system, and then only a couple more comments on our two expert speakers. To start off with, I think want to remind the importance of primary health care for universal health coverage, which has been mentioned many times, from the Alma Ata Declaration to the Astana Declaration in 2018. I think an effective primary health system is very important, so funding, likewise, should be devoted there. Health systems facing the challenges similar all over the world. I won't go into that, that has been mentioned. For Hong Kong's case, EK has pointed out a lot of things have to do with our value system, expectations, doctor shopping behavior of patients and all that. So overall, we think that it's behavioral changes that's needed in the public, the health-seeking behavior, and then also service provider, whether they can provide preventive services, many mentioned by a lot of the speakers, and also government policy. But in particular, I'd like to point out two things: the stewardship and resource allocation of funding in the Hong Kong healthcare system. And this is actually beyond strategic purchasing. It's part of it. But first of all, the stewardship, the fact that our main health budget goes to the hospital authority, and I'm glad I have a chance to speak before Henry. I'm sure he will be responding after this. I always mention purchaser-provider split. This is to ensure quality, because right now, Hong Kong system, I think majority of the health budget goes to the hospital authority, yet the provider of services is also provided by the hospital authority, including primary health services, and likewise the stewardship. So something needs to be, thought there, whether competitiveness, quality assurance, and also specific purchasing of services. Is that appropriate? Is that the best way? And then the other point is congruent conceptualization of primary health care. This is a thing that we're looking at. We always talk about primary health care, but maybe is it too selective primary care? In a way, strategic purchasing is a kind of selective funding, but that's fine from a purchasing point of view. But policy-wise, I think we need to look at primary health care as more holistic overall care, which is mentioned by the other speakers. And likewise, in outcome measuring processes, indicators, I think we need to break silos and really use the data, not just specific data in certain studies and all that, to look at the overall benefit of the improvement of healthcare financing. And likewise, capacity building of primary healthcare. I think we often are concerned that always talk about just family doctors, doctors, but actually it's a whole team, primary healthcare. So likewise, purchasing of services should be including other ancillary services such as nurses, physiotherapists, pharmacists, and all that. So I think it needs to be a very global view. And then with actually our development of the district health centers in Hong Kong, I think we are leading to that approach, is that there will be support to doctors to provide more holistic care. And just a brief mention, I think mental health is something that is part of primary health care too. It's no longer an institutionalized event. Now, just briefly on our speakers, our Korean speaker, Dr. Kwon, very interesting model in Korea. I'm particularly impressed with the long-term care insurance. This is what Hong Kong has been advocating in medical social integration, basically the care of people, not just curative, how to take care of the elderly. I think that is the model we should be thinking about as well in Hong Kong. As for Malaysia, the PICA B40, my small little advice is make more use of family doctors. Family doctors are in the front line and ready to provide ambulatory, preventive, anticipatory care. And then we can detect actually, because I noticed a lot of hypertension, non-communicable disease have not been detected. This is actually the job of the frontline doctors, whoever sees the patient first. What we always advocate that even if a patient comes in for a very minor ailment, you should be thinking about at least taking their blood pressure, checking the family history and all that. So I hope family doctors can get more involved in these screening purposes. But I think the government initiative of helping finance this would be most useful. So that's all for now, and
Thanks,
we'll
Dr. Lee.
more.
Let's try to see Henry, whether you can be back.
Can you hear me well
Yes,
now?
we can hear you
Stephen?
well. Yes, yes.
Okay, thank you. Well, first of all, EK, Eva, and Stephen, thank you for this opportunity to speak here, talk about strategic purchasing. Now, I think both Secretary Chen and Professor Eng-kiong had already given the audience some idea of what hospital authority do in Hong Kong. So I only need to fill in the gaps before we go into discussions. Now, Secretary Chen mentioned PPP program, which is something government and hospital authority have been initiating to do more and more. And as she said, government in 2016 actually gave us $10 billion, Hong Kong, to do this in 8 areas. And let me fill you in on what these 8 areas are. At the moment, we are doing it at cataract surgeries, hemodialysis, patient convalescence empowerment, radiological investigations, infirmary care, colonoscopy, glaucoma, and last but not least, primary care. Now, I want to specifically mention primary care because what we have been doing is our general outpatient clinic public-private partnership program has served as a platform to channel primary care service demand from public to private by utilizing the capacity and capability of our private healthcare partners. Now, this should please my friend Donald, who was raising this question earlier. At the moment, we already have 36,000 patients from HA receiving general outpatient clinics under the medical care provided by around 500 primary care doctors in the community. And we intend to do more because the expansion of primary care as well as the prevention of diseases are the key to the future of the sustainability of our healthcare system, as outlined in Professor Yu's Fitness for Purpose report, which I have personally read with great interest. And I think this must be the right direction to move ahead. And that is what we intend to do. And in fact, you see, in the middle of this pandemic, the hospital authority have been expanding our PPP programs into areas as were forced to cut back on other non-essential elective services as we enter into the fight for pandemic. So as a result, we have started some PPP program on cesarean, for instance, neonatal jaundice, even chemo treatment and so forth. So it is our intention definitely to look at PPP at a greater scale, to expand the scope of services over time, and to do more to cooperate with the private sector here in Hong Kong. See? Now, again, in answer Donald's question on the efficiency, I think the hospital authority is mandated by the government in the past 30 years to provide public healthcare services in Hong Kong. And as record shows, we have been treating, say, for last year, over 20 million patients at a total GDP of only 3% of Hong Kong's GDP value. See? So I think in general, the public considers our services to be efficient. And the fact is, we are now treating, as Professor Yao has pointed out, 90% of our inpatient services in Hong Kong. We do have governance rules, both for strategic purchasing as well as internal key performance indicators, which we keep under constant review to make sure our services are provided as efficiently as possible. So with this initial remarks, I would leave it to Stephen to continue with the panel discussion. Thank you, Stephen.
Thank you, Henry. Maybe I would actually throw the question back to Professor Yeo to sort of also respond to the two professors. For example, in Korea, what sort of interesting observations that you'd like to draw in terms of from the perspective of Hong Kong? What can we learn, or what is our observation from the Korea as well as Malaysian examples?
I think Malaysia, its a system, as Professor Ng said, is very similar to Hong Kong. It takes place. Primarily, originally, we were mainly very similar in terms of the outpatients, emphasis on inpatient. But I think what Malaysia has done slightly differently is to continue to grow their outpatients. Because Malaysia also has a big rural population. So I think they have expanded that. So that would obviously be quite good because it provides care where people need it. Whereas in Hong Kong, being an urban area, they've continued to to just build more hospitals. And so we have not addressed the primary care problem, which Donald talked about. And I think Malaysia, because there are quite a large number of low-income people, so the government's programs target that. And of course, because my updated PowerPoints were not uploaded, in Hong Kong we have the same problem of what we call health inequality. Because low-income people also not have a problem in access, but they also tend to have more health problems. So people in low-income families usually have a higher mortality, and they have a much higher chronic disease burden. In Hong Kong, in fact, we have similar figures. They're 14 times more likely to have a chronic disease than people from higher incomes. So you need to address that. Right? So in Hong Kong, because our outpatient clinics are limited in provision, so people cannot afford the chronic care when they go to the private sector. And that's why we continue to just squeeze our public system by limiting the number of outpatients, right? So people have no choice but to go to the private. And then you have this problem of coordination of care, which is the continuity of care is a big problem in both in terms of quality and efficiency of our system and sustainability. So government is trying to do that, but is it sufficient? And I think Korea is also quite interesting in their systems. And of course, they have got this long-term care insurance, which I think Professor Sun Kwan mentioned about even when you have one system, the coordination is a problem. So this is a problem because very often in long-term care, people have health needs. And one of the things we didn't cover is primary care coverage of our long-term care facilities, because that's the biggest problem. So currently with the COVID, during SARS, we had people from elderly homes going to the hospitals, and hospitals going back to the elderly homes because we don't have good primary care in the elderly homes. So that's also another area that needs to address. And I think the problem of the fee-for-service, I think is something that's quite important in terms of how to improve the efficiency from the payment systems. But I also want to also respond to what Donald talked about purchasing and purchasing. I think, Donald, because the PowerPoints maybe were not uploaded properly, strategic purchasing is really a continuous search for the best ways to maximize health system performance. So it's not passive purchasing, right? So it's not just about buying more of the same. It's really how the system should become more efficient. Obviously, for Hong Kong, the obvious answer is more ambulatory care and primary care, right? And then how to get the public and private to work as a system. So those are the levers, and strategic purchasing is quite important, but it's something that needs to be really looked at in greater depth. So it's not just what we're doing at the moment. So I don't think what we're doing at the moment is strategic purchasing. I think what we're doing is more responsive type of purchasing, right? Look at where the problems are and putting money to where the problems are. So when Mr. Henry Fan's public hospitals are full of beds, so we continue to build more beds. That's not strategic purchasing, right? It's just throwing money at where the problem is. And that doesn't attract it. Because if we put more and more money into hospitals, you're just like a marsh drawing more and more people in. It's like a magnet, right? Whereas we should be putting more money into outpatients, to primary care, ambulatory care, to take the people out of hospital, right? And most of the older people don't need to be in hospitals. So the figures that I showed you about the 50% ambulatory sense conditions is exactly the investments in primary care that we need, right? And also that PowerPoint that showed about purchasing primary care, I showed you the budgets of the government, the Department of Health, and the various parts of primary care that we're purchasing. Can we not use those resources better, right? Using that total pool of over $6 billion, right? Are we strategic purchasing what is required? So we need a mechanism to look at the problems, the issues, where the priorities are, and then where the capacity is, right? So I think that's what we're trying to look at.
So you're saying that the current PPP programs may not be strategic. They are purchasing, but they may not be strategic enough.
Right, because we have a lot of programs ongoing, but we don't look at the system. So when you look at strategic purchasing, you talk about maximizing health system performance, right? So that helps. I'm not saying that it's not, I'm not for a moment criticizing the PPP programs.
Right.
I'm just saying that we should look at in totality.
I see.
And of course, strategic purchasing needs to be looked at different levels. So it's the hospital authority's role as you talk about, how do you purchase from the hospitals? How do you, within the context of the PPP programs, what programs should be purchased and for whom? And government in the totality of budget allocation should look at all the providers, public and private, as a single entity and deciding if they want to provide more primary care, for instance, or more chronic disease. I asked the question, who should be purchasing, right? Is it government that should be purchasing or giving it to the hospital authority? And when you give it to the hospital authority, what are the conditions? What are the priorities, right? So at the moment, we are doing it rather piecemeal in little segments, but we don't let the thing in the system.
Can I also go back to, as we're on this discussion on primary care, invite Professor Kwan to talk about how, you mentioned about the strategic purchasing from a hospital as well as long-term care perspective. Can you also share a little bit more about Korea in terms of sort of primary care and whether strategic purchasing was part of the primary care system in Korea?
Okay, thank you. Well, I feel ashamed to say that primary care in Korea is very weak because almost all the graduates of medical school, they choose to become a specialist, board certified specialist. So we have, of course, we have office-based physicians. I mean, in the neighborhood, we call them physician clinics in the neighborhood, but almost all of them are board certified. Board certified in internal medicine, OBGYN, ENT. So first, the definition of primary care is very tricky, and many in Korea, we all agree that primary care is quite weak. It's very much of a hospital-centric care, very inefficient. So there are a lot of issues of avoidable hospital admissions because primary care is not very good. So in terms of qualifications, as I said, almost all office-based physicians in the neighborhood, they are board certified specialists. But we all know that does not mean that they can be a good primary care doctors. So that is one thing. And other thing is that in Korea, the health insurance agency, they purchase services from all providers, not just hospitals, but hospitals, physician clinics, all of them. Okay? But then, because it's a private sector dominated system, we are struggling with the coordination between providers. In other words, physician clinics are competing with hospitals because physician clinics, they are board certified specialists, and hospitals have huge outpatient clinics. So another issue is like long-term care, although it's good that we have a long-term care insurance, but that does not mean that we have a good coordination between healthcare and long-term care, because it's now two separate schemes. So we have another challenge of the coordination between healthcare and long-term care. So this is the situation in Korea where, I mean, different from Hong Kong, you have mainly the majority of the providers are public. So probably your challenge is more about efficiency argument. Of course, equity is also important. But in Korea, the majority, as I said, 90% of the hospitals are private. So if in terms of the productivity, in terms of the number of patients they treat, they are too diligent. They treat so many patients. So we can call it, you can call it, is it efficient or is it demand inducement?
We also,
I'm a bit of cynical about this. So that's the dilemma. But I think that what I question on Hong Kong, such that one of the most important elements of strategic purchasing is not just efficiency, but also quality. Because why do we pursue strategic purchasing? We want to provide quality care to the patient with a reasonable cost. I wonder what is how do you evaluate the quality of services after you introduce this voucher scheme?
Maybe that's a good question also for Mr. Fan. I also wanted to ask Mr. Fan, how do you evaluate the PPP program so far? And is there a sense of resistance sometimes? I heard people said, in the public sector, they feel that, they can do things better. Why do we want to outsource some of these other functions to the private sector? Is there a trust factor? Is there a quality assurance factor? How do we deal with that?
Well, Stephen, I don't think there is much resistance from inside the hospital from our colleagues. We have been cautious with doing PPP for two reasons. The first reason is assurance of quality control. We want to make sure that the programs would provide satisfactory services to the patients. And the second concern is not so much opposition from the colleagues, but some colleagues leaving us because of better opportunities outside of the public sector as a result of PPP programs. Now, we have to be careful with that as well. You see, say, joint replacement or things like that, where there are very few experts around. So these are two factors that's been, if you like, slowing us down on PPP. Now, having said that, we do intend to do more, but I personally see PPP as only a short-term solution to the sustainability issue. I don't think we can resolve the Hong Kong sustainability of our public health system issue by merely doing PPP. I agree entirely with what EK said. At the end of the day, there has to be prevention. And I keep going back to his fit for purpose report, which I personally buy seriously. I think it has to be prevention. And another trend that's been worrying us is this, that in addition to the issue of aging population, which I think the two professors have both pointed out, at HA we actually see a trend whereby the average age of our patients are getting younger. A group, I think Professor E.K. Yao spoke of people having chronic disease from 45, but we actually see the group between 40 and 60 becoming more and more frequent visitors to our hospitals. And that is really a worrying trend because on top of aging population, we would have this group who would be using more and more our public services, you see. So what is the key to that? The key to that must be prevention. How do we do more tests for these people, make them more conscious to test themselves early and to prevent chronic illnesses from developing? Because these days, I think food and everything, food, wine, everything is just so good that people tend to get diabetes or even heart diseases due to stress and so forth earlier than one generation ago, you see. I think that is really the worrying part for us.
I can share that personally. But let's go into the next session where we have some questions from the media and in the public general. And after that, we have a bit of a closed-door discussion. So first question from RTHK is to Professor Yeo and to Henry. Is related to this pandemic. Is there something more the private sector can do in combating this pandemic, as we all know that the public sector is quite overloaded? I understand that there are some PPP programs that Henry mentioned already post-pandemic, but is there more that the private sector can do directly?
I think we're doing this study and evaluation of our pandemic plans for government. And of course, as part of that structure, we look at the role of the private sector. So I think when we talk about private sector, there are three groups in the private sector. One is, of course, the private providers. So I think it's really in terms of many of the preparedness plans. I think very often when we do the comparative studies, some governments do it a bit earlier in terms of how do you involve the private sector in helping. I think now in Hong Kong, I think the private sector is helping, but I think they have not been involved early enough. I think in terms of some of the outpatient clinics, the non-emergency care, and then also as part of the surveillance, because many of the individuals don't go to the hospitals when they have symptoms, so they go to the private sector, and they're picked up when you go to private doctors for respiratory illness or for some fever, they're picked up by the private doctors. So really the protocols, I think initially that we involved them less, but now the government is involving them. So they're quite an important so-called sentinel site to really look at when governments are looking at expanding testing. We don't know what's happening in the community. Because I think the indications are the disease is already in the community, and it's going to be very, very difficult to eradicate it. And this seems to be the case all over the world. So the fact that we didn't have cases for 2 weeks, and suddenly when we relax measures that you get a big outbreak, means there are already some of these mild cases circulating in the community. They're not picked up. So we need to really work with the private doctors to really work in terms of preventing that. And also the private sector, I'll let Henry talk about supporting the hospital authority in his work. The second part of that is really the role of the private sector in supporting, because during this crisis, many of the older people do not get the services that they need, because many services are curtailed. The priorities go to COVID. So there's been a vacancy where the jockey club and many charitable organizations are picking it up. So that social support, social mobilization is something that in the future preparedness plans need to be planned way ahead, because currently it's more reactive. And the support to a lot of these people to provide care is not ideal. And the third part is, of course, the role of the public themselves in participating, because they are quite an important element in terms of the control. Because currently, because of that sudden relaxation, that everyone had a whole sense of relief. And then when you look at our restaurants and when you look at where the outbreaks are occurring, it's where there are groups of people sitting together. And then it's not just mass, it's also sharing of utensils of food, contamination of environments, closed environments where the ventilation is not good. Right? So because many of our restaurants are small, there is very poor ventilation. So ventilation is a very important part of the transmission, which is not emphasized enough. So in sort of those close and close areas, people need to wear masks. Of course, when you're eating, it's very difficult. So in those sort of environments, when government considers relaxing, they cannot treat all restaurants in the same way, because all restaurants are different, right? So Cha Chan Teng and the restaurants in the 4-star, 5-star restaurants or 3 Michelin star restaurants are very different, right? So one needs to look at the role of the community in helping look at some of these compliance issues, because the government itself cannot go around all the Cha Chan Teng to look at standards. So you can have compliance by peer pressures, compliance by the clients themselves, by people who frequent those. So they then choose. So government needs to give them information. What are the things that the restaurant should be doing? How do you protect yourself? Choose the restaurants which have these measures, right? So the public have a role to play to choose those restaurants where they have these methods of prevention. So they can play a much greater role.
Yeah, so this is Henry, if you can follow up on this. Also a question from Now TV on similar topic, and because a lot of the non-emergency services in public hospitals are suspended due to the pandemic. I understand that you mentioned the C-sections as well as the bone fracture operations, they have PPP programs, but there's only limited beneficiaries of 200 so far. Is there scope for bigger scope of the PPP to deal with this non-emergency during the epidemic to take care of these people?
Yes, well, let me first take up your first question, which is what private hospitals can do to help with this pandemic, which was partly answered by Professor Yeo. And I agree with him that the fundamental principle is we need cooperation from the community to be more pandemic conscious, you see. As far as hospital authority is concerned, we think there are 2 areas private hospitals can help. And as a matter of fact, we are in the course of discussing with some private hospitals. The first is in the area of testing. Now, the hospital authority labs are equipped to do about 2,000 tests per day. But as of this week, we are already in maximum capacity. In some cases, we did up to 6,000 tests a day.
Wow.
And still, we are beginning to see queues at various places, for example, Chinese medicine clinics and so forth, where people want to get tested, and at our A&E and so forth. You see? So I think what the private hospitals can do is, where they have the lab capacity, they can help us to do some tests for us, and we're in the course of discussing with them on that. You see, a second area where some private hospitals may be able to help is to assist with setting up step-down wards. Now, as you know, we have a total of about 1,200 isolation wards. Some of them are now under renovation. So in the short term, we have about 1,157 and so, and it's quickly filled up. It's quickly filled up. So we are now planning, and this is going to happen immediately, to have some steady patients who can fulfill certain criteria set by experts into what we call the tier 2 wards, which is more for recovery before discharge, because they are no longer infectious or less infectious. Now, we have 500 of those at the moment within the public health system. Now, what the private hospitals can do is to help us set up these tier 2 wards, if they can. Because if they can spare wards, then we can have some steady patients download to these step-up wards, and that is going to help the public system, you see, to get better. Now, insofar as PPP is concerned, non-essential services, this is easier said than done, because private hospitals also have their capacity limits, not only with manpower and so forth, but also with their own PPE supply. So not many hospitals are willing to take up too many of these non-essential services, because they too have to provide for a rainy day. But we would try to expand as much as we could. But at the moment, the priority must be to deal with this third wave of pandemic outbreak.
Thank you.
So that is the position.
Thank you, Henry. With that, I know still there are a lot of questions, but because of the time, we thank you for all those who sent in questions, and we have to end the public live session for now. And thank you for all those who joined on our public live session. And now we turn into the closed door session, where we have our fraternities and friends, as well as obviously our panelists, and we have 4 also special guests as well that zooming in to.
By the way, please excuse me, I should leave. So it was a great meeting. Can you hear me? So I should leave the meeting.
Professor Wong, can I ask you one question?
Yes, please.
I know you talk about a lot of public insurance, like your long care, but are they paid by individuals or paid by government, the insurance policy?
No, it's in Korea, public insurance means that it's mainly funded by individual contribution. Government provides some subsidy, but in the overall funding, government subsidy is about 15 to 20% out of the total funding. So that means about 80%, 85%, 80% will be paid by individual contribution. payment.
Okay, thank you very much. That was the important part about the financing angle. So it's basically the public sector has to buy the insurance. Thank you.
And what if people cannot pay? People can afford to pay.
So there are, for the poor people who cannot afford to pay contribution, so government subsidy comes in. So when I